of you might be familiar with Grady. You might have seen us on the news transporting our Ebola patients. So this is the news article that was seen around the world. Some of you might be familiar with us because we were featured in one of my favorite shows, The Walking Dead. But unfortunately, a lot of folks are familiar with us because we were the largest health system in the Southeast, and we were on the verge of bankruptcy. So we did get a lot of philanthropic funding, a lot of donations. I think the term earlier was a shit ton of money. But we knew had to do something. We had to make a lot of changes. We had to implement technology. So in 2011, we implemented EHR systems, integration, HIE, and in 2016, we were named the most wired for 5 consecutive years, and then we earned the most wired again in 2017. So we've come a long way. So Grady EMS, it's a hospital-based EMS provider service at 911 in Atlanta, and we've grown to other counties. We do about 120,000 annual transports per year and still growing. Since 2013, we've actually improved our collections per transport by 12%, and collectively we've increased our aggregate revenue by 73% with growth and improved billing. And we're going to tell you how we're going to do that.
So as a lot of you guys in this room, you have been digging out from the 2008 economic collapse, and we're definitely in that group. We really looked at how to expand our footprint, expand our business model. In Atlanta, we're really dense. It's only 132 square miles. So geography, we're not a big space, but we're about just under 120,000 responses in the city limits of Atlanta. We had a lot of economies of scale. We were starting to learn a lot about billing, revenue cycle, analytics, and we really kind of figured out that we really need to expand. And so we basically became a competitor in the market. We took over an acquisition an event company. We started doing specialty care transports, and then we expanded into now 15 rural counties and really tried to focus on regionalization through economies of scale, and then obviously through our business model. So obviously there's some pain points. For us, operations is expensive. You can't cut paper clips, and everybody knows you can only do so much, and then you have to focus on the other side. You look at your expenses. We know ambulances are expensive, but at some point, there's just no other, you can't beat the employees more productively. You can't drive your unit hours up any higher. You got to keep down your overtime. So you really kind of get to the side where you go, I got to focus on the other side. We lost a $6.9 million county subsidy. So we were basically told late 2008, you're on your own. And so that's pretty big for an urban EMS service. It's high volume. At the time, it seemed devastating. And today we think, thank God, because we really have come a long way. And without that, we'd still be in the same rut that we were back then. Tammy's going to cover a couple of other points on the slides. So I'm just keep skipping on. So obviously we had to work on this expansion. We really wanted to find a sustainable model for us, and we really had to figure out how are we going to fund these capital dollars year over year? How are we going to replace ambulances as new technology and cardiac monitors? All that stuff's expensive. And we really, for employee engagement, a lot of our employees that were coming into our organization saw that it was really a ceiling very quickly. Our FTOs had been there a long time. Our supervisors were in their 30s, sometimes early 40s, and then that was it. We had an ops manager, and they said, gosh, I'm just not going to stay here because I've got to grow. But with all this expansion came new positions that we hadn't envisioned before, more leadership, more supervisors, more managers, regional directors, VP positions. And through that, we realized quickly that we didn't have the guys and girls that had the financial background. So we encouraged them to go to school, get a degree. We definitely worked with our hospital. We're hospital-based to provide tuition reimbursement, so we do about $5K a year for that, and really said, look, there's positions coming, and there's a spot for you if you'll grow with us. You're just going to have to go to school. But in the interim, we really focused on trying to teach them that side of the business. It's easy to teach, fairly easy to teach a mid-level manager about how to manage salaries, how to keep costs down, medical supplies. how to manage overtime and a schedule. But when you get to the billing side and you start pulling in a lot of these analytic report cards and scorecards and EPCR lens, these guys are like, gosh, this is really completely outside of what I'm comfortable with and really what I understand. And so you have to kind of show them, here, look, here's a lot of questions you can ask. But then when I talk to the manager, it's like, look, I'm an ops person. I got to figure out, how do I tell Bob, the employee, that he's doing a good job or a bad job? I can't go to shift huddle, 4 times, 5 times a day. We do, 14, 15 shift changes, and go to my guys and go, you're not doing your accuracy billing, you're not getting phone numbers, you're not getting addresses. We got to get to the employees to manage that better through accountability. We also looked at, obviously you guys do system status deployment. We look at a lot of those kind of things, where we put our trucks, reducing our time on task. We found that we really, from dispatch to in-service, we got to be under 60 minutes, and we put a lot of processes in place to have that. That's how we back into our schedule, our response times, our UHUs. In order to do all that stuff, it's 60 minutes or less. We worked on some mobile integrated health processes, and worked on crew turn times. And this is that report they're pulling out as well from our system that says, hey, look, you're able to run a call in 45 minutes on the average this month. This person's at 65 minutes. You got to get it down. You got to be quicker. Here's kind of our footprint of our call volume. You guys have seen these kind of heat maps that help identify where to do unit deployment for our system status management models. And then our next big step, of course, our loyalty customers. And this is a big thing for us. When you're talking about loyalty customers, we can look in our regular EPCR software and we can look at a loyalty customer, a frequent flyer, see how many times they're coming. But you can't see what it's really costing you or what kind of outstanding charges you have out there without this billing side. So you can kind of see, this is a Digitech report. And as he pulls this up, you can kind of see that we got a guy here, $293,000 in outstanding charges, 0 revenue, and 169 rides in our truck. If you start thinking about that, if every call runs about an hour, he spent about 7 days in our ambulance. Okay? So we really got to look at these things all the way down to the patient side and the employee side to try to sort out how we can get ahead of this. We have mobile integrated health. We've got 2 trucks. We have one that's a paramedic and a licensed clinical social worker that goes to all our mental health calls. Instead of an ambulance, we have a nurse practitioner and a medic fly car that does not only 911 responses, EMS high users, but we do readmission reduction as well. But the main piece of this is to try to get to these patients that come out of this report, these super expensive ones, and find solutions for them.
So we focused on 3 main solutions for improving cash flow and provider documentation. And that was really expanding our QA program to look at documentation review for both clinical protocols and get them familiar with looking at better billing documentation. We also brought on a new billing vendor, which is here with us today, Digitech Computer Inc., which had a higher caliber of technological capabilities. We had outsourced billing, but we just needed more data to make more improvements and move the bar. And with the new data technology and the reports that we'll be showing you, we were able to heighten our financial analysis and manage a large number of employees with a small amount of data. And that helped us to implement transparency, accountability, and also competition between our division leaders as well as our medics. So we started with training. Our QA officers and some of our leaders went out and got billing and coding certifications as well as Lean Six Sigma certifications so they can look at process improvement. We worked and did a lot of work with Digitech on real-time feedback, documentation, scoring, giving them ongoing training through classes, as well as current reports on how they're doing. We gave them scores on their documentation. And we implemented a lot of the documentation into new orientation hire classes. So we kept that going. And as we were able to have data on how they were doing, we introduced the recognition, and we also introduced discipline. So this is an example of some of our dashboards. So these dashboards can be filtered in over 1,000 different ways. You can customize your dashboards for operational KPIs or key performance indicators, or you can look at financial KPIs or a combination of thereof. So these are some daily KPIs that some of the finance folks look at: general sales, accounts receivable, cash receipts. We also have some operational reports. You can look at your transport volumes per month. This helps with staffing. You can staff up and staff down according to your percentage of transports for those month. Really cuts down on overtime. We also look at payer mix. We use payer mix for quite a bit of looking at new business as well as current business. We look at trends in self-pay. We know that 1 or 2% is really going to affect our cash flow. So if we see a spike, as we did in May of 2017, we dig a little bit deeper. All of these dashboards are high level, and they can be drilled down to the division level, the truck level, the medic level, and even the patient account level. You just keep drilling down. So what we do is when we see an increase in self-pay, we look at documentation accuracy. We compare our divisions. So the report before this, we compare our divisions. Each of our divisions are given a score. We introduce competition, and then we get down to the medic level. And we look at this in two ways. We look at data collection, and we look at data accuracy. For example, you can see Adam West. He was actually at an A when we were looking at data collection, but when we looked at the accuracy of the data he was gathering, he went down to a B. And we know we have those medics that find the workarounds. They'll just put something into required fields. So we really focus on accuracy. Daisy here, she has a C when you look at just data collection, but when you look at accuracy, she actually goes up to a B. So we really focus on quality and not quantity, and reiterate that we are looking at the documentation and data collection. There are registrars, it's important, so we really measure them on this. And this is the EPCR lens with Digitech. So all of our leaders, like Mike said, we really focus on getting our leaders and expanding their education and maybe going and get bachelors, but we also educate them. I'm finance, Mike and a few other on his team, their operations, so we combine the two knowledges, and we teach our leaders to look at EMS as a business unit. So each of our division leaders really understand what their collection per transport rate is, what their net and gross collection rates. They look at their payer mix, and they use this financial analysis scorecard quite a bit, or analytical scorecard quite a bit, but you can also run it and summarize a whole year or prior year, and you can get averages pretty quickly. And we use this when we go into new counties and we're looking to project new business and what the revenue is going to look like, and we compare it to expenses. So we'll have an idea of what our profit margin is even before we go into these new counties. And then we have some other reports. We're just going to show you these kind of quickly. Revenue by medic, so we can really monitor where performance is declining. We can also monitor when they're improving, do some performance improvement plans, coach them up. Sometimes we got to coach them out, but we really focus on high performers and low performers now that we have the data to back it. And we compare revenue by station. We don't look at numbers because some of our counties are smaller, but we look at deviations in numbers. If there's a month that's off that division's average, then we're able to see that pretty quickly. Drill down, look at the issues, and fix it. We look at cash flow on a regular basis. You can run reports by data service, so you look past and look at mature data, or you can look at your trending for the year. We held Medicare claims for the deductible a little bit longer this year, so you see a dip in 2017, but then you see consistency after that.
So now I guess it's my turn. Hopefully you can hear me. I'm kind of in a unique position where I was a former client of Digitech, and I served as a paramedic firefighter for 32 years with Gwinnett County Fire Department. In the last 6 years of my career, I worked in the business services division where I utilized Digitech's reporting software every single day. So things that I think that a billing company should provide for you is an increase in transparency into your data. You should be able to drill into the reports all the way down to the patient care report. Have complete transparency of the entire billing process. You also need complete access to the technology, and not only access, but it needs to be easy to use. You need to have ongoing training provided by the billing company, both on-site and electronically. And you need to be provided constant interaction and information about ongoing changes and the KPIs that you're evaluating, as well as upcoming federal changes that may impact the revenue that you're collecting.
So we tried to do our billing inside, or in-house, and we just didn't have the technology. We didn't have the expertise. We were a hospital, so we had hospital billing teams that had no idea about EMS, and even though it's only a few codes, it's got its nuances. So we tried billing in-house. It wasn't working, so we outsourced to a vendor, and we saw some improvements, but we needed a lot more technology and data analytics to move the marker and really be able to increase our revenues as well as move forward and grow. So we brought Digitech on in 2013, and you can see that it just keeps going. So we're seeing a lot of success, but we couldn't do it without the data. So our dashboards have been key to our performance, our movement, our improvement, but it's also been key to drive the change. And we have transparency, we have competition, we have accountability. Those scores that you see between the medics, they're posted everywhere. So it really gives them, and then we recognize with gift cards and some financial rewards. And we're teaching our leaders, our EMS leaders, to be more business-minded, to build their business acumen, and they couldn't do that without data. So we're really interlacing the clinical expertise and business acumen for higher results.